All right. So, can you see this PowerPoint?
Yes.
Okay. All right. So we're talking about delirium and approach to the agitated patient today. Let's see if this works. There we go. So we'll talk about background, patient presentation, differential diagnoses, treatment, and then we'll cover the questions. So, okay, I'm gonna have to move this little box.
Great picture. Great picture.
Great picture.
Yeah. Great picture. Yeah. I never seen it before.
Um, so the incidence of violence in the emergency department is among the highest in the hospital, which is why this is relevant to all of us. 71% of EM physicians have witnessed an assault in the emergency department. 97% of assailants were patients. And in the last year, 28 to 62% of physicians report having been assaulted. Patients can become violent for a variety of reasons. So we have to rule out life-threatening sources of agitation in these patients. So we can't just assume that they're psychotic or, have a psychiatric disorder. We have to make sure they don't have a medical reason for why they're so agitated. So what we need to do is try to de-escalate them as quickly as possible using the least invasive method, because it is beneficial to the patient as well as to us. So these patients are often unpredictable, as I'm sure we're all aware. And then the key in management is to provide for the safety of the patient and the safety of us. Because basically what we want to do is we want to calm them down and then be able to perform a medical workup and safely be able to obtain lab results or imaging or whatever we need. So some definitions here. Delirium is an acutely disturbed state of mind that occurs in fever, intoxication, and other disorders, and is characterized by restlessness, illusions, incoherence of thought, confused thinking, and a lack of awareness in someone's surroundings. It usually comes on fast within hours to a few days, which is really important to remember that it's fast and it's not like slow onset, like something like dementia, or also usually psychiatric illnesses. If you're seeing someone with their first psychiatric break, they've usually had some sort of symptoms leading up to it. Maybe it's just like a little vague depression or something, but usually they have something. And then psychosis is the disruption of normal thought patterns, usually with the presence of delusions or hallucinations without insight. Psychosis can be a symptom of delirium. So, you could have delirious patient that is psychotic. You could also have a psych patient that's psychotic. So our most important thing to do is to differentiate between primary and secondary etiologies of agitation, delirium, and don't assume a patient has a psych disorder if you don't have some history to tell you that. If you have a patient with visual hallucinations, this is very suggestive of a secondary or organic cause of psychosis and not a psychiatric disorder. Also, if you have a patient that's greater than 45 years of age that has new agitation, this is also more likely to have an organic etiology. So we have to be detectives and look at their vital signs closely, perform a thorough history and a thorough physical exam. We have to evaluate them carefully because these patients with psych illnesses or altered mental status, they're at increased risk of presenting with concomitant medical problems. And our psych patients, they oftentimes cannot advocate for themselves because they can't express themselves like a normal person can. So for me, like if I have a psych patient that tells me they have a cough, I'm more inclined to do a chest x-ray on that patient than I am a normal person that tells me they have a cough, because a normal person can easily express to me what their symptoms are and everything, whereas a psychiatric patient might not be able to. So we actually should probably do more for these people and not do less for them. So differential diagnoses for your agitated patient or patient with delirium. There's so many different differential diagnoses, and you don't have to do like full set of labs and head CT and all these tests on all of these delirious or agitated patients. But you have to think about all of these diagnoses in your mind and then decide, why do they not have this illness and why do I not have to do these tests? And if you can't say that definitively, then you should do the test. So anytime I have someone, whether they're like 20 years old or especially if they're older than like 30 years old and they're presenting with a new psychiatric complaint, I'm definitely doing a full set of labs, checking their thyroid, checking a head CT. And so we'll go through these differentials, and it's very broad. And I'll tell you some of the ones that I've seen, I guess. So differentials, they can have increased intracranial pressure. So they could have intracranial hemorrhage, edema from a stroke, which I actually just had a patient last week that presented. He was like 65 years old, came in for psychiatric complaints, complaining of suicidal ideation, but also was like disheveled and wasn't taking care of himself, which was new for him. And he had a new stroke, didn't have any neurologic like deficits on exam. It can also be caused by trauma or mass effect, herniation, a mass occupying lesion, hypertensive encephalopathy. I also had a patient in the last week that had hypertensive encephalopathy that was extremely psychotic and had very difficult to control agitation. Then I've also seen a patient that had a history of breast cancer, and she came in with new psych symptoms, and it was because she had a metastatic mass in her brain. Other differentials: hypoxia, hypercarbia, hypotension, hyper or hypothyroidism, a CNS infection like meningitis or encephalitis, any other infection, especially I'm sure we've all seen urinary tract infections in elderly patients and they become delirious. Seizures and intoxication or withdrawal syndromes, which we see, like Di was saying, all the time in the United States. You can see psychosis from steroids, alcohol withdrawal, benzodiazepine withdrawal, someone taking hallucinogens, someone taking stimulants. I've seen, I think, all of these cause altered mental status. Metabolic abnormalities, so hyponatremia, hypoglycemia, uremia, hypocalcemia, hepatic encephalopathy. Again, I think I've seen all of these. I had a psych patient who was had known psychiatric disorder. This was like a few years ago, and he had some like vague complaints associated with his psychiatric illness. But when I asked him, I did a very thorough history and thorough physical exam, like I do on all of the psych patients, because again, they cannot express themselves like normal people can a lot of the time. And the only thing he complained about, I asked him, like, have you been nauseated? Have you been vomiting? And he said, yes. And then he actually vomited when I was in the room, and his vomit was like pure water. So normally I wouldn't necessarily do labs on him because he was very well known to our emergency department. He has a known psychiatric disorder, and he's coming in for vague psychiatric complaints like depression or something. But I was like, let's do labs on him because again, he's vulnerable, and his sodium came back and it was 107. So he got admitted to the ICU. Other differentials: multiple sclerosis, porphyria, Wilson's disease, Huntington's disease, sleep disorders, vitamin or mineral deficiencies, Addison's disease, Cushing's disease. I actually diagnosed someone in the emergency department with Wilson's disease, which is, these are your zebras. So I don't know if you will say this in Vietnamese, but we say when you hear hooves, you think of a horse and not a zebra. But sometimes you have to think of the zebras when it comes to psychiatric patients. Sundowning or dementia-related aggression. discomfort. So people can be psychotic because they're in severe pain. And if you give them opioids, their psychosis all of a sudden resolves. Urinary retention. And the final thing is obviously psychiatric illnesses can cause psychosis. So we have to think about all these other possibilities before we assume a psych disorder, though. You'll never diagnose all of these things if you don't think about them. So it's always good to review all these weird things. For treatment of our agitated patients, there's 3 goals. We need to prevent harm to the patient and healthcare. We need to rapidly control their behavior, preferably without making them unconscious or go to sleep. And we have to recognize and treat their underlying etiology early. So how do we do this? First, we're going to try verbal de-escalation if appropriate, and then second, chemical restraint, and third, physical restraint. So verbal de-escalation. When carried out effectively, it can prevent agitated patient from requiring physical and chemical restraint, which is obviously beneficial for the patient and the hospital staff because it avoids violence associated with other types of restraint because you're not tackling your patient or jabbing needles into their arm. The way you do this is you're supposed to make sure that you are safe, utmost and like most important. You need to, it's not really relevant, I guess, in CHO-RI, but you should keep, if the patient's in a room, you should make sure that you are next to the door. So don't ever put the patient in between you and the door. Make sure you keep a distance of at least 2 arms lengths from the patient. Avoid prolonged eye contact. And don't approach the patient from behind or move rapidly because it could be threatening to them. When I do my physical exam on a psych patient, I always tell them, like, I'm going to listen to your back now to listen to your lungs so that I tell them exactly what I'm doing. Whenever possible, you should agree with the patient so that they feel like they have power. You should keep a low tone and maintain a calm, soothing manner. Introduce yourself, emphasize that you're present to keep them safe. Do not convey weakness or vulnerability. Be concise in your speech. You should make them feel like you're there to help them. And you can try to win brownie points with them by offering them things like food, water, blankets. You should listen to what they're saying. So make them feel good. Set clear limits, always be honest with them, offer choices and optimism. So if the patient is really agitated, I usually, and you think there's somebody that is willing to take medication, I always ask them, do you want to take some medicine to help you calm down and feel better? And very commonly they will say yes, which makes everyone's life easier. You give them a pill instead of jabbing them with a needle, and then they significantly improve. And then if none of that works, you can always like kind of threaten them with force and show them like security officers, and sometimes that calms them down. Next, we have chemical restraint. So again, some patients will cooperate with oral medication, so try that first. But most commonly, they don't. So you have to do intramuscular medications because if they're so agitated, you can't get an IV in them yet. You should always do chemical restraint before you physically restrain someone, because if you physically restrain someone that's wide awake and agitated and psychotic, you're going to increase the risk of them harming themselves in their restraints and also rhabdomyolysis. So our medications that we use, it's mostly benzodiazepines or antipsychotics. It's best to tailor which medications you use to why you think they are agitated. So here's some of our agents and their doses. So if their underlying problem is psychiatric, you should choose an antipsychotic. If their underlying problem is sympathomimetic overdose or methamphetamine overdose or alcohol withdrawal, you should give a benzodiazepine. If it's an elderly patient, and let's say they're the one with the urinary tract infection or delirium or whatever, You should half your doses and give an antipsychotic, and do not give benzodiazepines if possible. The reason is benzodiazepines has been shown to increase falls, prolong hospitalization stay, and it can worsen their delirium in elderly patients. And then if they're severely agitated, you can use ketamine. So here is a nice algorithm that I found that kind of breaks it down by what patient you have. Yeah, I can send that out if you want. So severely agitated patient. Rhabdomyolysis is a frequent complication, and ketamine has the fastest onset of action compared to IM benzos and antipsychotics. The ketamine dose is actually really high, which I think I would be a little bit scared to give that much, but apparently, I mean, there's many sources that say this dose is safe. So 4 to 6 mg per kg intramuscular, or 1 to 2 milligrams per kilogram IV. And you can also, in your severely agitated patient, use a combination of medications, which we often do in the United States. And we have like little nicknames for them. So what I trained with was, we called it B52, which is Benadryl 50 milligrams, Ativan, so lorazepam 2 milligrams, and haloperidol 5 milligrams. So it's a very nice cocktail. And then here in Utah, they use one called Dropkick, which is droperidol mixed with lorazepam. You have to watch for side effects of the medications and fully monitor the patients after you've given them significant doses of chemical restraint. So antipsychotics, we know, can prolong the QT interval and cause extrapyramidal symptoms and dystonic reactions. So dystonic reactions are involuntary muscle contractions. And if you have a patient that has that reaction, you can give them Benadryl to help stop it. Benzodiazepines can cause sedation and respiratory arrest, requiring intubation. And again, it can worsen delirium in elderly patients. So if chemical restraint is not enough, or sometimes you have to do these simultaneously, but you, again, always do chemical restraint before or simultaneous to physical restraint. So you should apply restraints to all 4 extremities. Only restraining 2 extremities or 3 extremities is actually more dangerous to the patient, and it's less secure. The reason is that they can maneuver themselves in the bed, and they can like flip the stretcher and cause injury. So this is how you are supposed to physically restrain a patient safely. You're supposed to assemble a team with at least 1 person for each limb, and at least 1 person to apply the restraints and administer medications. So you're supposed to have a minimum of 5 people. Each person is supposed to apply pressure proximally to the knees and elbows. And you should apply the restraint to the wrists and elbows, and if necessary, across the patient's thighs or pelvis. You can also consider placing 1 arm up and 1 arm down, because apparently that helps restrain them better. And it makes it less likely for them to be able to flip the stretcher. You should always have them supine when they're in restraint so that they don't suffocate. And unfortunately, sometimes with all of this, we still cannot control these patients with verbal de-escalation, chemical restraint, and physical restraint. So you have to sedate them and intubate them to facilitate our medical workup. Because again, that's our goal, is to calm these people down enough to be able to safely get lab results from them, catheterize them for urine, get the head CT, whatever you need. And I had a patient like this week that I had to intubate because she was so agitated, and it was from methamphetamine. Here is just that algorithm broken down step by step. I couldn't fit it all on one slide. So if your sedation is not achieved by like giving one dose, then you can just give more medications. Any questions before we go to the questions? Let me open this chat if I can. No, I can't get the chat open.
In our department, we just have midazolam and haloperidol to just only two medicine for this situation. Yeah, and after that we check CT scan to rule out stroke or hemorrhage in the patient. After that, we usually consult with neurologist. Yeah.
Oh, really? That's good.
Yes. Yes.
Nice.
And sometimes we take a sample plus to transfer to another place to control many substances we can do in our department and our hospital. For example, amphetamine. I know that because I have a patient many days ago.
Yeah.
We check some substances, for example, amphetamine, bromazepam, caffeine, carbamazepine, ibapramine, methanol, etc. Yeah.
Yeah. Good.
Yeah. 24 hour later, we have a result.
Okay.
We don't have many experience about in this situation because after control the patient, we transfer the patient to neurology department. Yeah.
I see. Okay. Dr. Dye, do you use haloperidol and midazolam also? Yeah. Okay. Nice. All right. Shall we do these questions? So, a 23-year-old man is brought to the emergency department by police. He was acting bizarrely at a local mall when he was found. On arrival, the patient offers no history and is highly agitated. Vitals cannot be obtained secondary to patient agitation and him swinging his limbs trying to strike staff. The patient states, "If you don't get out, I'm going to destroy the place," and begins throwing medical supplies. Which of the following is the most appropriate next step in the care of this patient? And I can't see this chat for some reason. So can someone yell something out?
Usually, maybe this is the dangerous situation. Maybe we do retrain the patient with the self-retrain.
Maybe what?
Retrain the patient with the self-retrain.
Okay. So it's actually first we want to give medicine. So So administer IM olanzapine, which is like the same as haloperidol.
Yes.
We have. Yeah.
We don't have olanzapine for IV or IM in our department, and I think in Vietnam we don't have that.
Yeah. Okay. Yeah.
Yes.
So it's just you don't have to use olanzapine. That's just of these options. It's an antipsychotic.
Yes.
So you would say administer IM haloperidol.
Yes. Yes.
Yeah.
Right.
Or maybe B52 or one of these mixed drugs. So he's putting himself and others at risk. So he requires chemical restraint. You're not going to be able to like verbally de-escalate this situation because he's putting himself and others at risk. So you just give him a shot. And then I agree that I think he would probably need restraints as well. But first you have to give medicine at least first. If not, you could do like simultaneous to your physical restraints. Okay, next question, which I guess you all don't have ketamine, do you?
Yes. C, we choose C. Oh,
Yep.
no. C, yes, that's right.
Yeah,
C.
you're right. Which, yep. So the correct IV ketamine severe agitation dose 1 to 2. Good job. So yeah, 5 milligrams per kilogram is the intramuscular dose.
Yes.
And then like A 0.1 to 0.3, that's the pain medication dose. So analgesia. All right, next question. An 86-year-old man with history of coronary artery disease complicated by heart failure with reduced ejection fraction, osteoarthritis, and hypertension is boarding in the emergency department while waiting on inpatient placement. He has received IV antibiotics, IV fluids, and vasopressor support in the setting of urinary tract infection that led to septic shock. The patient became agitated and began pulling at a central venous catheter and indwelling urinary catheter 2 hours ago. He received a dose of olanzapine 5 milligrams PO, which again is like haloperidol, with mild improvement, but the nursing staff has frequently needed to redirect him to help maintain his IV access and indwelling urinary catheter. He becomes acutely agitated again and is now demonstrating efforts to strike staff. What is the best next step in the management of his acute agitation?
Try
stop.
Use haloperidol.
Yes.
Haloperidol IM.
Yep. Sorry.
Great.
Exactly.
Yeah.
So he's an elderly patient. So we are not going to choose benzodiazepine if we have an antipsychotic available. So agitation treatment in the older population should start with verbal de-escalation, orientation tools, treatment of any underlying contributing medical conditions. If medication is required, first line is low doses and up titration of oral medications if the patient is a harm to themselves or others. The use of intramuscular or IV medication should be used if the agitation is refractory to oral agents, as in this patient. Antipsychotics are first line recommendation, not benzodiazepines. Are you? Sorry, I can't hear you if you're trying. What was I going to say? I forget. Oh, one thing to think about with elderly patients, which I guess it's not really relevant in the emergency department really, unless they're staying in your ER for a while. But if you have someone that's like deaf and has hearing aids or something, it's important to like get them all their home things, like their hearing aids, put their glasses on them. Like all of these things can make their delirium much better. Or bring a family member and like have a family member sit with them and just constantly have like a familiar environment around them. All right, next question. So a 23-year-old man with a history of schizophrenia presents to the emergency department with auditory hallucinations. He states he has been hearing voices telling him to hurt himself for the past week. He has not been taking his prescribed medication for a week as he ran out. He is unsure of the medication. He reports no use of drugs or illicit substances and is requesting voluntary admission to the hospital. His temperature is 99 degrees. Vital signs are normal. Physical exam, a young male who appears unkempt and in acute distress. He is responding to internal stimuli. He is cooperative and willing to take anything that makes the voices stop. Which of the following is the most appropriate treatment for this patient?
I choose C, oral lorazepam.
Okay.
Yes.
So it's actually D.
Oh.
Because yeah, so because he is he's a psychiatric disorder, so you want to give him an antipsychotic.
Yes.
Yeah. So oral olanzapine would be like the same as haloperidol. And he's willing to take oral medication. So you're absolutely right. You should give him something oral. They're often safer to administer, may avoid a traumatizing experience of intramuscular administration.
Yes.
Yeah. So.
Thank you, Craig.
Yeah.
We usually lorazepam.
Yeah, I understand. I do that sometimes too.
Yes. Yeah.
Yeah. So elderly patient or psychiatric patient that's willing to take medicine, we're going to give them oral antipsychotic.
Yes.
If it's somebody that's like an overdose, then we'll give them benzos.
Yeah.
All right, next question. This is, I think, the last one. An 18-year-old man presents to the emergency department in police custody after using an unknown drug. Vital signs include blood pressure 170/85, heart rate 120, temp 37.8. Others are normal. On exam, he is agitated and diaphoretic. His pupils are 7 millimeters and reactive. Which of the following substances did the patient most likely use, and which medication should you give him for his acute agitation?
It's A.
Yep, A. So he used cocaine.
Yeah.
So he has sympathomimetic toxidrome, and we know it's sympathomimetic and it's not B, which is an anticholinergic, because of this one piece of history, which is diaphoretic. He's diaphoretic.
Yes.
Yeah. And then you're right that the treatment is going to be benzodiazepines because it's an overdose. Sound good? And I think that's it. So I don't teach again until December. So I will see you in December, and I will be suffering in this snow in the winter. This is my first time living in Utah, and I'm so nervous.
Yes. Oh, fantastic. So cold for me end of the week. And on doctor in Vietnam. So cold.
I know. It's so cold for me too. And I'm from here, but yeah. All right. Any other questions? Oh, I see the chat now.
It's very nice to learn with you this lesson because we don't have many experience about this situation. Yeah.
Yeah.
A little patient, especially younger or young boy, usually come emergency department at midnight. The same that they usually use cocaine or amphetamine, but a little patient, they usually choose the right hospital, another hospital to go. To go to hospital, they don't choose. I don't know why. I don't know why they don't want to choose UMC for this situation, especially young people and I. Yeah, that they usually like Dr. Dai and some doctor in Chiang Hospital. So we don't have many experience. It's very fantastic for me end of the week to learn with you this lesson.
Oh, good.
Again, because sometimes we you wrong. We make you make a wrong decision for the patient. So we chat again. Thank you very much.
Like Dr. Dai, yeah.
Yes, I know that I want to say something.
Hmm. Yeah, is it not methamphetamine or crack? Huh. Oh, interesting. Hmm. I actually heard about a case here, or, well, not just one. There were like several cases. They didn't know what the substance was. Yeah, maybe it's that. Maybe it's already made its way here. They're like really like hypertensive and tachycardic. Do they go into do those patients go into like rhabdo? No. Okay. Hmm. Hmm. Yeah, I'm not teaching until December.
That's correct.
Oh, I don't know. It's either Claudia or Jonathan.
Sure. Okay.
Yeah. And then they'll have like, I don't know, three or four, and then I'll be back. Thank you.
Thank you, Sally. Thank you very much.
Thanks. Bye.
Bye bye. Thank you very much. Yes.